This is Dr. Patrick Hu, CEO of Moffitt Cancer Center, and we're coming to you from Orlando, Florida, where we're at the annual AACR meeting, and it's my pleasure to have Dr. Ahmad Tarhini from our cutaneous oncology program here with us today. So, Dr. Tarhini, thanks so much for being here with us.
My pleasure. Thank you, Patrick.
Tell us what you're presenting. You're involved in a number of projects here at AACR.
True. One specific product we're excited about is data we're presenting this afternoon. It's about an immune gene expression signature predictive of immunotherapeutic benefits for high-risk melanoma. With the exciting emerging data in the adjuvant and neoadjuvant setting, in melanoma, key questions remain related to biomarkers and the optimal patient selection for the right treatment. Can predictive biomarkers allow us to select, what patients have the capacity to respond to immunotherapy and treat them while saving others the unwanted toxicities and risks in the absence of predicted benefits? Can prognostic biomarkers be utilized to accelerate progress in the adjuvant and neoadjuvant setting, treat only those who would relapse? What are the key mechanisms of resistance with immune modulator therapeutics? In order to better inform combinatorial approaches, and what patients have or are predisposed to develop serious immune-related adverse events. So we have taken some of these questions and tested them in the context of a phase 3 study, E1609, that we previously reported and tested adjuvant therapy with ipilimumab compared to interferon alpha. We analyzed immune microarray gene expression data from patients treated with ipilimumab and patients treated with interferon alpha. We then developed a Lasso-Cox regression model generating a biomarker risk score based on the top genes that were selected in this model. And then we tested this biomarker risk score in patients treated with ipilimumab, interferon alpha, and then we validated the data in an independent study that tested neoadjuvant ipilimumab. So the risk score that we called LIPI7 for Lasso-IPI7 was based on 7 genes, the expression of 7 immune-related genes, and was effectively able to predict overall survival in patients treated with ipilimumab. We were able to stratify patients into high risk or low risk in the IPI-treated population. Then, as a negative control, we tested the same risk score, LIPI7, in patients treated with interferon alpha, and it failed to predict survival there, supporting the predictive value of this signature in relation to ipilimumab treatment. Then we tested it in an independent study, a neoadjuvant study that tested ipilimumab, and there too we were able to significantly predict the relapse-free survival of those patients. We looked at interactions with clinical covariates and found significant interactions between LIPI7 and age, gender, and the on-treatment development of immune-related adverse events. For example, female patients that had a low-risk LIPI7 score had the best survival outcomes there. So we're excited about these data. We are planning prospective validation in the context of a neoadjuvant study that we're close to activate at Moffitt, and looking forward to share our data at future meetings.
Well, that's very exciting. These are important questions because as a melanoma doctor myself, I can tell you there's almost a wealth of agents now for melanoma therapy, some with high toxicity, others with lower toxicity. And the question is what to give what patient. And so hopefully this will help to answer that. You used a randomized study, ipilimumab, which is anti-CTLA-4 against interferon. Now, a lot of patients in neoadjuvant and adjuvant therapy for melanoma are getting anti-PD-1 agents, such as nivolumab or pembrolizumab. How do you think this 7-gene signature will affect these patients or be applied to these patients?
Yeah, thank you for asking this question because we will present the data this afternoon as well that we tested this immune-related gene that appears to reflect an immune-enriched tumor microenvironment in an independent cohort of patients with metastatic melanoma treated with anti-PD-1 as monotherapy primarily, a small fraction with IPI plus Nivo, and a small fraction with ipilimumab as first-line treatment. And there too, we were able to see significant predictions of benefits with this immune-related signature in that patient population as well. That's why we think in the neoadjuvant study where we will select patients if they're predicted responders into neoadjuvant anti-PD-1 as monotherapy, and their predicted non-responders, we're going to randomize them into combinations. And we will not only focus on this signature, we will look at other biomarkers as well. Maybe more simpler biomarkers could give us the same information, we'll see. But that's something we're planning to test prospectively in those patients.
I see. So you're trying to distinguish patients that are going to do well, so you give less therapy and less toxic therapy, if at all any therapy, right? And then the patients that are at higher risk, then you'll increase to combinations even like Ipi-Nivo that have more toxicities.
Correct. Agreed.
Great. Wonderful. And so when is your next study going to start that's going to look at a number of regimens based on their score?
It's in submissions at Moffitt, so close, I think, for IRB submissions. The expectation within 2 to 3 months will be active.
Wonderful. Well, very important studies. We have Dr. Ahmad Tarhini from our cutaneous oncology clinic at Moffitt Cancer Center talking about the important areas of biomarkers in the treatment of melanoma patients. Thanks so much, Dr. Tarhini, for being here today.
Thank you, Patrick. My pleasure.